Hey future RNs, today we're going to be talking about postpartum hemorrhage, specifically early postpartum hemorrhage. So please take out your notes, your pens, your pencils, and jot down some notes, because if you want to do labor and delivery, you will see this. It happens a lot in the hospital, so you will see this. So please subscribe and like, and we're just going to get into the content. Hi future RNs, so we're just going to get into the subject. We're talking about postpartum hemorrhage today. What you need to know. This is important because we see it every day on the floor. So what are some of our learning objectives for today? Well, we're going to understand what postpartum hemorrhage is. We're going to review what are its causes, the risk factors, the signs and symptoms. We're also going to go over the treatments for postpartum hemorrhage, and we're going to review some NCLEX style questions about that subject. So what is postpartum hemorrhage? Why are we talking about it? It is the most common and dangerous complication of childbirth. It is defined as blood loss more than 500 mL for vaginal birth and 1,000 mL, more than 1,000 mL for cesarean section. Postpartum hemorrhage is a major cause of maternal death and morbidity, and it complicates about 1 to 5% of births in America. If hemorrhage occurs, of course, in the first 24 hours, then we call that early postpartum hemorrhage, and this is what this video is going to focus on. But if hemorrhage occurs after 24 hours and up to 6 weeks, then this is called late postpartum hemorrhage, and we'll have another video on that one. What are some of the causes of postpartum hemorrhage? Well, let's think about the 4 T's. Jot this down because this is important. The 4 T's of postpartum hemorrhage. Number 1 is tone, trauma, tissue, and thrombin. So don't forget the 4 T's of postpartum hemorrhage. It has to do with the tone, has to do with trauma, the tissues, how are they affected, and of course, thrombin, how is the body reacting to that loss of blood. So an example of tone issue is uterine atony, and I'll define that a little bit later. For tissue, it's retained placenta. For trauma, a hematoma, for example. And thrombin would be that the patient is having coagulation problems. The risk factors of early postpartum hemorrhage, there's a lot of them, okay? So overdistension of the uterus, some examples of why the uterus would be overdistended is multiple gestation, multiparity, a mom who has 3 or more babies, a macrosomic baby, a baby that's 4 grams or more, polyhydramnios, a lot of amniotic fluid that really distends that uterus. A distended bladder, why? Because it pushes that uterus up and it prevents the process of involution from occurring. A retained placenta or placental fragments. Previous surgeries. So if you have a patient with a history of a myomectomy, for example, that's of concern because she may bleed after a vaginal delivery. Placenta previa or accreta. Prolonged and precipitous labor. Oh yeah, her uterus really contracted fast, got the baby out quickly, and now it's weak. And medications used to induce and augment labor. All of our patients in the hospital are usually on Pitocin. So a lot of the medications that we use, if it's too long, it can actually cause the patient to go into postpartum hemorrhage. Another risk factor of postpartum hemorrhage is actually obesity. Research shows that women with a high BMI are prone to having uterine atony. It may be as a result of maybe having weak muscles and also having a lot of fat or in or around the tissue fibers of the uterus. Also, if a patient had a vacuum or forceps delivery, manual manipulation of the placenta, or a uterine inversion, fibroids, clotting factors or disorders, using medications such as magnesium, which is a muscle relaxant. And after the patient delivers, because we had her on the magnesium before, now the uterus is like, I'm too relaxed. I don't want to contract. We mentioned previous surgeries. And if a patient has had PPH with her first pregnancy or second pregnancy, and now she's pregnant again, she may be prone to having PPH again. Placenta previa and accreta, because those placentas are not implanted in the proper place. And like we mentioned before, a distended bladder or urinary retention can push that uterus up and away from midline, which can cause overstretching and uterine atony. So what are the signs and symptoms of early postpartum hemorrhage? Well, usually it's a boggy uterus. So the uterus is just weak and tired and it says, I don't want to work anymore. So no more contractions. So a boggy uterus actually feels a little bit like your nose, very mushy, but we need it to be as hard as your forehead. So a bright red excessive lochia, excessive clot are expelled. Constant trickle, dribble, or slow seeping of blood. Those are not good signs, guys. A high fundal height, like I said before, from urinary retention. The patient is saturating pads one after the other, sometimes every 15 to 30 minutes. That's way too much. Tachycardia is an early sign of postpartum hemorrhage as well, and then it leads to hypotension. So as you see, guys, we need to treat these ASAP, right? As early as we can, because if we don't, then this patient can go into hypovolemic shock and have pallor and eventually faint, and we do not want that to happen. So what are we going to do? Let's talk about uterine atony, which is again a lack of muscle tone. We need to stop the bleeding, right? And this is just a picture that shows you, you see this uterus? It's supposed to be a very strong muscle, but it looks weak and tired. And if you felt it abdominally, you would see that or feel that this muscle is very weak and it's not strong. So in order to prevent that, let's talk about some things that we can do. So the treatment for postpartum hemorrhage, number one, we are going to massage that uterus. No, we're not going to do effleurage. Absolutely not. We're going to really dig deep and massage that fundus so that it can turn back into a hard contracted muscle. Okay, as hard as your forehead. Another thing that we need to do is a rapid infusion of Pitocin after the delivery of the placenta. We also give Methergen IM, Cytotec per rectum, and Hemobate IM. If these don't work, then the doctor or the midwife will do bimanual uterine compression, and we'll do that for a while to see if the bleeding will stop. A uterine balloon and packing sometimes is done. If we've gone through all those different measures and it's still not um, stopping the blood, then definitely we'll try to use a uterine balloon or packing. And as a last resort, guys, they may have to do a hysterectomy. So volume replacement is very, very important in postpartum hemorrhage. So we give them lactated ringers. Sometimes we give them PRBCs, so blood transfusions. And that is why it's so important when a patient is admitted to the hospital to do a type and screen and a CBC. Very important. And there you go. This is an example of bimanual compression of the uterus to stop the bleeding. Let's talk a little bit about fundal massage. So guys, like I said before, you don't want to just, passively do a little bit of effleurage for the mom. No. First, you're going to, right above the symphysis pubis, you want to hold what I call the neck of the uterus, okay? The isthmus. And you want to hold that, and then you want to palpate for the fundus. And if you feel like it's like soft like your nose, you want to go deep into the abdomen and start massaging it. And the deeper you go, and you really have to massage hard. And I usually warn my patients because sometimes they'll grab your hand and I say, let go of my hand, please. So sometimes I'll have the dad or the significant other actually hold their hands, or I'll have them grab onto the side rail as I do that. And of course, I explain to them that in order to stop the bleeding, I need to make sure that that uterus becomes firm. What are some of the nursing management or nursing considerations that we have to do? Again, we already did a type and screen and an admission. We did a CBC. We put in a large bore IV in the patient. Okay, we usually give them LR. That's the main fluid that we use on the OB floor. But if the patient is bleeding a lot, the doctor may decide to do a blood transfusion. What the QBL, or the quantitative blood loss, is, we have to do pad counts. So if a patient is saturating a pad, we need to weigh it. And of course, when you weigh it, you're going to remove the dry weight of the pad, and that will be the amount of blood that the patient has lost. We do also fundal checks every 15 minutes. Yes, guys, every 15 minutes. Again, you need to massage that fundus, make sure that it's firm. If it's firm, you don't have to massage it, okay? Because if you over massage, it can become boggy again. So if it's boggy, go ahead and massage it to firm and make sure that it's at the umbilicus. And also every 15 minutes, we're going to do a set of vital signs because again, the first sign that the patient is bleeding too much is tachycardia. So are you noticing that her pulse is increasing and her blood pressure is decreasing? Again, we need to notify the midwife or the doctor. So trauma is the second most common cause of PPH, early PPH. Like I said, it could be from the vagina, the cervix, the perineum, or developing a hematoma, maybe in the labias or the perineum, or even inside the vagina. So risk factors of trauma. Well, what can cause trauma during a birth? Well, if you have a really large baby, okay, can really tear you up. If you had a precipitous birth, right? So your body started contractions, the contractions were so violent and so quick that you expelled or delivered the baby very quickly, usually less than 3 hours. If we gave you medications for an induction or to augment your labor, that can cause you to have trauma as well, because again, the contractions may be strong and expel the baby too fast. And also malposition of the baby. Some babies come out with their hand out, or some of them come out with their foot out. And so those things can cause trauma. Now, hematoma basically is blood vessel injury. So blood vessel injury during a spontaneous delivery or an assisted delivery. So bleeding into the connective tissue while the overlying tissues remain intact. So it's like you're getting a little bubble filled with blood. Okay, and that's very painful, guys. So it's deep. The patient will complain of unrelieved pain. So even though you've given them ibuprofen, you've given them Percocet, and they're still saying that their, pain is a 10, please assess them. Look at that vagina, that perineum. Open the vaginal opening just slightly, just to look inside to see if you see a hematoma. And if you don't see it, it may be deep inside. It may be a cervical hematoma. So please make sure that you notify the midwife or the doctor, and they will assess. And the only way to relieve this, guys, is a little bit of surgery. They have to lyse it so that the fluid can come out, the blood can come out, and finally the patient will have relief, right? So this picture just shows you all the areas in which a patient can have a laceration. So lacerations, we usually measure it in degrees, okay? So it could be a 1st degree, 2nd degree, 3rd, or even a 4th degree laceration, which can go all the way down to the rectum, to the anus. Okay, and that was one really painful. So please give them some ice and give them their pain medications. Okay. All right. So let's test your knowledge. Which of the following would put the client at risk for postpartum hemorrhage? Delivery of. So please, guys, if you want to pause and take a second, read the answers and tell me what you think it is. Okay, let's see what you guys chose. So if you chose number 3, absolutely number 3, why is this the answer? So even though she delivered a baby that's 6 pounds, that's not a big baby, but notice it's only 2 hours. So this is what we call a precipitous labor. So from the onset of her contractions to when she delivered the baby, that uterus really contracted really fast, and expelled the baby really fast, and then it became weak. And so this usually causes uterine atony that we need to treat. Next question. Which client would be identified as having early postpartum hemorrhage? Again, you guys can pause the video and look at the answers and tell me which client is more at risk for postpartum hemorrhage. If you chose number 2, you got it right. Remember I said that for a vaginal delivery, postpartum hemorrhage is anything above 500 ml, and for a cesarean delivery, anything above 1,000 ml is considered postpartum hemorrhage. All right, next question. Which client is at greater risk for early postpartum hemorrhage? Again, pause the video, look at the answers, and try to pick one. So if you guys said an obese client who has had 5 or more deliveries, you are absolutely right. So just being obese or having a high BMI makes you at greater risk to have postpartum hemorrhage, but notice she's had 5 deliveries. So she is what we call a multi-Paris patient. And that uterus has been stretched and deflated and stretched out and deflated. And after a while, it goes, I don't want to work anymore. Okay, so these patients, we give maybe 2 bags of Pitocin after their deliveries. And we do a lot of fundal checks, okay, and massages too, so that the uterus can recontract and go back to the involution process. So next question. A postpartum patient has left her peri-pads in the bathroom for the nurse to assess. The nurse notes that there are 4 peri-pads that are saturated with blood. The first pad weighs 40 grams, the second, 35 grams, the third, 60 grams, and the fourth, 45 grams. The dry weight of the pad is 10 grams. What will the nurse document as the quantitative blood loss? So I want you guys to pause and really think about this one. I'll help you in the end, but please pause it. Okay, let's see, guys. If you pick number one, hooray, this is the right answer. Why? So one thing you guys could have done is add all of the weights of the pads, and then you would do minus 40. Why? Because each pad is 10 grams. So you take the cumulative of the total weight and you minus the 40 grams. And that would have been given you from 180 down to 140. Remember, a gram is an ml. A gram is an ml, okay? Or what I do, I know I make things a little complicated, is I remove the 10 from each pad. So instead of saying 40 grams for the first one, I would say 30. Okay, so it would be 30 plus 25 plus 50 plus 35. And that would give you a total of 140 mLs. All right, guys, so this is the end of our video for today. I hope you enjoyed it. We will talk about postpartum hemorrhage, but we're going to talk about the second one, which is late postpartum hemorrhage in the next video. So please like, subscribe, press that notification bell, and please feel free to comment. And we will have more OB video contents coming out, so please stay tuned, all right? It was a pleasure, guys. Take care.